Welcome to Sex Ed for Adults. I am Jessica Ross, a certified sex therapist and clinical trauma specialist. Here on Sex Ed for Adults, we focus on the intersection of sex and everything else. Today, we are at the intersection of sex and disease. A person's sexual health, as stated by WHO, the World Health Organization, is not just the absence of disease, dysfunction, or infirmity. It is the state of physical, emotional, and mental and social well-being in relation to sexuality. This emphasizes that sexuality is an integral part of life. Chronic disease can impact sexual functioning by disrupting the desire and aroused phases of the sexual cycle. Today, I am joined by Traci Owen, a registered nurse at Cancer Treatment Centers for America in Tulsa, Oklahoma. Traci's focus as a sexuality counselor and educator is sexual health and wellness. She works with both individuals and couples to address concerns connected to relational, intimacy, and sexuality. Her work with people includes helping to address sexual concerns related to various medical diagnoses, cancer treatments, and menopause. 75% of doctors do not ask about sexual functioning, and yet we know most patients have questions or issues related to sexual health and functioning. Many people feel dismissed when they do ask questions about their ability to have sex, changes in sexual desire, fertility, or sexual functioning. We assume that individuals that have a chronic disease or have entered menopause should no longer be thinking about sex and intimacy. However, we undervalue how important connection is for hope and healing. We fail to acknowledge that the partners are impacted too, and closeness is a meaningful space in a relationship. Traci is a nurse, author, mother, wife, and grandmother, and today she joins us to discuss sex and disease. Welcome, Traci.
Thanks. So good to be here. It's kind of fun to connect up with you again.
Yes, so Traci and I went through the University of Michigan Sexual Health Program together. All fun, all laughs, more laughs out of class than in. But it was certainly a good experience, and I am very glad to have met Traci because it's been enlightening getting to know, someone from just a different area of background, but Traci's also a lot of fun. So I just can't imagine how much the people you serve love you and love working with you. So, how long have you been a nurse, and how did you end up working in oncology?
Well, I was one of those people who I have a strong spiritual being to me, and she has a very loud voice. So, I knew really from a very young child that I was called to be a nurse, that would be my role. And so my whole life was kind of geared toward that. At 17, I was already gearing toward nursing school classes. So I graduated with my bachelor's at 22. I went to work. I've done trauma medicine. I've done case management. Along the way, someone thought it would be fun to do administrative nursing, and that was not my gig. But I learned a lot from it. It's the beauty of being in those beyond those a little bit middle ages, is looking back and saying, okay, this is what I learned from that time. So it really did have great value. It wasn't my favorite role as a nurse, but I learned a lot and grew as a woman. So as I was ready to step back into patient care, I went to Cancer Treatment Centers of America. I love the philosophy that they come with. It's about embracing the whole body, mind, and spirit. And so I've been there almost 12 years of my 31 years as a nurse. And about 6 years ago, really came a little bit before that, came to see that sexuality, when you started looking at the couple and the treatments for chronic health issues like high blood pressure and diabetes and cancer, all of those things have tremendous impact in the sexual body system. And if we're going to impact the sexual body system of an individual, then if that person's partnered, we're going to impact the relationship with that couple. But really what I saw is that we weren't dealing with that. There really isn't a voice for that. And again, I felt very propelled, very called to pursue this. And I'm so thankful for that. Now I look back 6 years, I'm like, yes, this was intentional. This is purposeful. So I work with the individual on the sexual body system, and you think about just menopause, which is a natural thing every woman's going to face in her life. How often when a woman's going into menopause does her GYN or her physician sit down with her and say, hey, these are some of the things that are going to be happening in your body as you move through this menopausal experience. These changes are coming from this for this reason, and here are some things that we can do to try to stave that off, keep things healthier while we have this opportunity. My husband thinks that we should do a menopause class, like a quarterly couples menopause class, where we just come in and talk about the impact of menopause on the body and on the biggest sex organ that we have as well. And so you take the menopausal impact, and then you get some breast cancer in your 20s or your 30s. That experience is going to be very different for that woman in the 30s and younger category, the 40s to 50s category, and the 60 plus, just because the bodies are all in different places. And so in our society, we've never given a voice to the sexual body system. We were born with it. We were born as sexual creatures. We're going to die as sexual creature. And whether we're having sex, we are still sexual beings, and we still have a body system that needs to be cared for, because for women, that can have a lot of impact on urinary health, vaginal health as far as recurrent infections. It can impact the bowel health. If we don't keep the vaginal canal healthy, hydrated, and strong, then that's where we get these kind of protrusions of bowel or bladder into the vaginal walls. So there are reasons to deal with sexual body system that don't have anything to do with the act of sex.
I like that. So tell me this, Traci, how does someone end up seeing you? Is it a natural part of the process, a part of their treatment, or is this a special request that patients would have to make?
Both. So for certain medical diagnoses, such as breast, GYN, urinary, rectal, prostate, penile, testicular, any of those, we know we're going to be manipulating sexuality in that body system. And so that's an automatic referral to me. And my place in that is healthcare has done a really poor job of representing a very natural process of the sexual body system. And there's all kinds of social burdens that people carry, experience burdens that people carry about sexuality. So it really needs to be someone who isn't just trying to check off a box. But we start that with an intro with those people, just to, hey, my name's Traci, this is the program, these are the things we're going to be working on. And then that lets me bring in the body, because so many people are so withheld about sex that the thought that they're going to come talk to a sex nurse is really intimidating for them. So by us removing that fear for them and just letting this quick introduction come by for me to say, these are the things we'll work on together. This is about you. This is about serving you where you're at and your needs in today's body. And we'll see where our relationship goes from there. But by doing that, we've taken away the pressure that they feel to ask.
I love that. I
Because
really do.
People don't ask. How many
No,
times?
I agree.
How many times men will go to the doctor? They're gonna talk about their erectile dysfunction, and they get there and they get so totally bound up with it that they never bring it up. So they might go to the doctor 3 times for some other BS complaint, and really it's because they wanted to talk about their erection and no one asks. So if we know that 40% of 40-year-old men are going to start having erectile failures, and that only increases with age, we should be asking men about that. We should be giving them the outlet to that.
No, completely agree. I see people that get to my office, they've been brave enough to find me. And so then I ask, have you talked to your medical doctor? Have you talked to your urologist? Have you seen an OB? And they're, no, I have one. Okay, you've had a concern for 3 years. Have you ever had that conversation? Have they asked you? No, they didn't ask, and I'm not going to tell. And so a lot of my work is just trying to bridge a relationship and with them to go see a provider, right?
Yeah.
Because I have my lane, but then there's a space that you really do sometimes need medical intervention. And some of it is just building the strength to go down that avenue, right?
Absolutely.
So that is a lot of what we're working on. Let me
And
ask
just
you
giving
this.
people language about their body. I've found, you know, I'm an RN, so I'm not prescriptive. I can't prescribe a medication. But what I can do is help a gentleman be more comfortable in the conversation. Like, here are the things that you need to be prepared to answer. What would your answer be? Let's go ahead and talk about it. Let's practice that conversation. You're going to have a list, and you're going to have your top 3 things. You're not going to have a list of 40. You're going to have your top 3 things. And let's go see your doctor, and then they're more prepared. It's like a little coaching session, right?
Yeah, absolutely. Absolutely. But the fact that they have you as that advocate and that support, right? And then if we're doing our end on the therapy end, we're also doing something very similar to what you're doing in counseling. So in what you've seen, what is the impact of receiving a diagnosis of cancer or high blood pressure, diabetes, or epilepsy? So not even the treatments or what's going to happen after that, but when people first receive their diagnoses, what does that impact like?
Well, of course, it's going to depend on what the diagnosis itself was. I mean, you know, I've been a trauma nurse, so I've had to have some pretty horrific conversations with people. And I work in oncology, which is a pretty heavy conversation. So, you know, I think those conversations can only be led from the heart. And I think that people really look to us on how they're going to react. If we have our stuff together, we have what the next step plan is going to be, to start having those discussions when we can let them know that, yeah, this is really hard news, but we're going to be in this with you. And, you know, that's really been the role of a nurse all along. You know, that nurse is typically the person who helps people through, helps a couple, helps a family, helps a person through some really hard, difficult decision making at times. So I think how we bring it to them greatly impacts how they receive it. You know, when I hear people say, oh, somebody called me that I didn't know who it was, and they called me on the phone and told me that I had cancer and it was stage 4 and we probably need to call hospice, you know, that's a pretty in your face conversation. And so, you know, the delivery is imperative. How much heart are we bringing to whatever bad news we're bringing? And how are we going to respond with a plan? Because that's what people really need in those hard times. They're not ready to learn at those times. You know, this is the medical model of this. And as a nurse, I've seen this my whole career. Medical model is very, see a problem, identify a problem, treat a problem, move along, right? That's medicine model. But that's not who we are as humans. And so when we give these really hard informations, we then try to come right. The next person in the door is trying to feed a bunch of information. Well, there's no way this brain has any room for all of this stuff. You know, this is still over here in this visit going, what? So I think timing is very important. And not only I think the presentation of the hard information, but then the timing of the education and planning is very imperative. Some people want that like right now. Some people say, I need just a day or 2 to chew on this before I'm going to be ready to do that. And we have the responsibility, which I don't think use very well at times, of letting that be in their space and not our schedule.
I agree. I absolutely agree. I know some of the things I've received medically could have been delivered a lot differently, because you're absolutely right. How it's delivered does impact how I receive it or how a person might receive it. So what are some of the most common diagnoses that you see or that come into your office?
Predominantly, all of my people are going to, the high majority are going to have cancer of some sort, either in their history or active. We did open up in the Tulsa area. I'm in Tulsa, Oklahoma. We did open up for our community. People can come in from the community just for an appointment with me, and they don't, that non-dependent of a cancer diagnosis or treating at cancer treatment. So I have people that come from other facilities to see me, and then I just have some that are referred from the community. You know, I'm one girl. So my brain and my heart are always in yes mode, and my body sometimes is lagging a little bit behind my yes. But there aren't a lot of folks doing this work, and you know, especially when you attach it to chronic health, and which is why I think the nurse is truly the ideal medical person for these conversations. You know, we've always lived within that biopsychosocial spiritual model. That's how that's how nurses are trained. That's where we start. And you know, we're with people through some of the darkest moments of their life and some of the most celebrated moments of their life. We're the people right there with them when those things happen. And so you to be successful in this field, you have to be able to really meld and flow and move with whomever you're with at that time, because everyone comes with a different need.
You're very insightful, Traci. Can you explain to the viewers, how is sexual functioning, impacted by cancer treatment?
So if we always say, if you're a woman still having periods, we're going to probably over time, we're going to put you into a menopause, whether that be a chemically induced from medications or surgically induced through surgery. My experience, and that's just me, so that's not speaking for the whole world, but it seems to me that the women who are 45 and under have a much harder transition into that sudden menopause, because, you know, their bodies haven't been revving up. By 45, most female bodies are already slowing in their hormonal production. You know, they're already becoming a little perimenopausal. So that can go on for 3 to 7 years of a woman's life before menopause actually happens. And if a woman's really young, when we put her on treatment, we may only be putting her into a temporary menopause. So even though maybe we wouldn't want her getting pregnant, we still have to be very cognizant of birth control and in a non-hormonal way. And I don't, you know, those are conversations that are hard, because for some of these women, they've never had a baby when they're diagnosed, and now they have a hormone positive cancer. So, you know, do we then pump that woman's body full of some more hormone to create a bunch of eggs that we go into harvest, which delays treatment time for that woman, because now she's got a pump full of hormone, egg retrieval, and then on to treatment. So, you know, there's a delay there. But there's also the side of some women can go on to have a baby later down the road. So, you know, you never get to know at the start of the story what it's going to, or you're going to travel. So my thought is always, well, I want to pack a little bit of something for each of the scenarios. And sometimes it makes sense to have a woman harvest eggs, and sometimes it just doesn't make sense. And it depends on how aggressive her particular cancer is. But that's a hard conversation. I mean, you're telling a woman in her 20s, 30s that she won't be able to have a baby sometimes. And that's what a grief that is, in the middle of being also told you have cancer.
Yeah, completely.
And the relational piece of that, like, is my mate going to stand with me through this? How's he going to feel? Am I cheating him of not having his own children? I mean, those are some pretty heavy conversations for those couples.
Yeah, it's, as you said before, a complete biopsychosocial, spiritual impact on who a person is, and not just because they have been diagnosed, but because they've been diagnosed and they're seeking treatment. What about for men when we're talking prostate, testicular cancer, or some of the other more invasive cancers? What's happening with them in terms of sexual functioning?
You know, I try to see people again, I try to see all of those rectal, bladder, prostate, things that we know will have some immediate, for sure, impact on sexuality. I try to see them up front. And I tell you, my heart has really grown for men through this conversation of learning. In my experience, like, I know what the experience of being a woman is, right? Like, I know the pressures that we get. I know the messaging that we get, you know, and it's heavy, and we all know what it is from our perspective as a woman. But I've had to step out of my woman shoes and into man shoes and really try to live it with them. And what a heavy burden this is for so many men. Like, their sense of who they are as a man has been so tied to their sexual virility in their life.
I see that a lot.
And so if I can't get an erection, then does that mean I'm not really a man? Or why would my woman stay with me if I'm not really a man? That's why I think we see so much, you know, men oftentimes will struggle for years with erectile dysfunction. And they get so anxious in their brain about it, and so depressed about it in their brain, and so angry about it in their brain, that it's carrying so much burden in them that then they begin to separate off from their mate. Like, they're not reaching out and holding hands. They're not hugging, touching, kissing,
shutting down.
You know, so if a woman's been pursued by that same man for the last 25 years of their marriage, and suddenly he's not pursuing her anymore sexually, and we can't talk about it because he gets angry and pulls away, then what's happening in her head? He doesn't find me attractive anymore. He doesn't want to be with me anymore. Oh my God,
there's somebody else.
My boobs are sagging. He's got a mistress. You know, and none of that is true either. So I feel like being willing to open the conversation as a healthcare provider helps to start building a bridge. And so at our facility and within my community, I know I have relationship with different mental health providers. You know, they have their lane too of different things. We also have a great mind-body medicine team at Cancer Treatment. So I have someone I can bounce with really well. But if I start talking to people as we're going through our intro about prostate cancer, testicular, and I see a couple who's had long-standing struggle in their marriage, long-standing issues in their marriage that long predated the cancer diagnosis or the healthcare issues, then our mind-body medicine, I'll get with them, and they'll kind of work on that stuff. And I get relationship in the place of, this is what's happening in your body, and how can we adapt our sexual experience despite our medications? Does that mean we change up timing of our medications through the day? Does that mean we change up timing of our sex through the day? If a woman or a man has cancer in the pelvis or the femur, some of those big bones, how can we have sex safely? What positions can we have sex in? I mean, those are all things that no one's ever going to think about asking these folks.
And that was exactly what I was thinking, is who's going to ask them those questions, or how would they even know to ask those questions? So I'm absolutely glad that you said that. I want to jump from cancer to menopause a little bit. You talked about menopause in the beginning. What is it? What is menopause?
Well, so a woman's estrogen and progesterone and her little bit of testosterone that she makes are made in the ovaries, down in the pelvis, and a little bit of sex hormone is made by the adrenal glands that live on top of the kidney. And then estrogen itself is stored in fat cells, and that's true for men and women. So as you see fluffier folks like me, we're going to have a natural higher estrogen level just because of what's stored in our body. So when we talk about hormone blockers and things like that for women, that's what we're talking about. Blocking are the fat and the the adrenal glands if she's already postmenopausal. But the ovarian function is purely about keeping the uterus ready to make a baby. So the estrogen's going up at one point, building the lining of the uterus, and then as it comes down, the progesterone's coming up and we're shedding that uterus. So it's just kind of this ongoing cycle of keeping the baby's house prepared. So when our body is no longer in baby making mode, and that's usually sometime between 45 and 55 is when a woman starts her menopausal journey, then she'll start making less and less of those natural sex hormones. And that's what brings in menopause. So when a woman, what we usually will see is a woman will start to have irregular periods, like instead of, I've been an every 28-day girl my whole life. And now it's like it can come day 26, it can come day 32, you know, and it just starts kind of spreading out and getting a little irregular. We count a woman menopausal when it has been 12 consecutive months since her last period. So what's happening in the rest of the body? Well, almost all women are going to begin to notice some hot flashes, right? Like the world is suddenly a hot place to live in.
A little personal summers, right?
Personal summers. And so I always want to talk about personal summers because they can be really heavy for our younger women who are being chemically put into that menopause. Talk about, what are common triggers? So we talk about spicy food, alcohol, caffeine, chocolate, sugar. We talk about layering of clothes. We talk about timing of medications. There's a couple of supplements you can try, all the way up to some prescriptive things that we can try. Kind of the agreement at my facility is that I'll start with all the non-prescriptive, the supplement things that we can do and the behaviors that we can look at. And if we still can't control the symptom, then they'll go on to the quality of life doc for some intervention, perhaps with prescription. But I'm always a girl that says, let's figure out what we can do as a starting place that doesn't involve jumping straight to a prescription, which is hard in a world where we live, where everyone just wants to come in and get a pill for something. Like, I don't really want to work on it. Just give me a pill.
Absolutely. Everybody wants that quick fix. In the process, I tell people all the time, if I had a magic pill, I'd give it to you, but I don't, so you're stuck with me.
At work, I have a little bitty wand, and I'll say, so my wand doesn't work, but if my wand did, what would you wish for? And then, okay, now knowing that the wand doesn't work, how can we accomplish what you want without the wand?
And this is why you're a counselor.
So
that amount of empathy and compassion is amazing.
Well, you just have to be willing. I mean, I live in Oklahoma. We've got our share of farm boys here. And so the messaging to farm boys is pretty heavy. So I have to really go with a lot of analogy. Like when we're talking about female desire in a menopausal woman who's also dealing with other health issues such as cancer, as you can imagine, that sexual brain has so much hitting it that there's not a lot of space for desire in there. So I want to talk to our men and let them know, listen, this is what's happening. This is why it's happening. It's not that she doesn't desire you or want you. It's just about, we have to do it different than what we used to. And so like I have an analogy where I talk about the slower response time of a woman at different times in her life, when desire is not the first thing that arrives in the room. And we're trying to augment that thinking to be desire dependent, to being curious, and to seeing how you respond to the action. And so I'll tell men, I'll say, think about a diesel engine in Minnesota in the winter. You can't just get in and drive that diesel engine down the road in a Minnesota winter. It has to be warmed up. It takes some time. And once that engine gets warmed up, it's going to run for you just like it's supposed to. It's just going to take a little longer than getting in and driving. And a lot of couples have learned about sex by getting in and driving. You know, there's not a lot before. There's not a lot to the warm up on their
warm up.
And so, you know, I consistently am having to talk to people about what's on your menu. Let's, you know, okay, you've been married for 25 years, you've had sex every Saturday night and Wednesday night with the lights out in the missionary position. Okay, well, maybe that's just, we need to add to your menu a little bit. I mean, you might love fried chicken, but I bet if you had to eat fried chicken 3 times a day, every day for 20 years, you'd be like, I can leave the chicken.
Yeah, that variety, that expansion, right? That adding something to what has already been. So what do you propose that people with these new diagnoses should be asking their doctors, right? We hope that we would love if every center or every medical department had someone like you on their team, but they don't. Right? They don't.
I was the only RN in our class, if that tells you anything.
Yeah.
And I think each class has maybe 1 or 2 nurses. I feel like part of my calling, I thought it was just to serve my people at cancer treatment, but I truly do feel like my calling is more in establishing a pathway in the medical profession. And I think the nurse is the great girl to do it.
Yeah, I absolutely agree. So what should people be asking their practitioners?
I think first, I always tell people, you know, you get all brave and you have this big list and you blow it out. And then it's sometimes deflating. I say start with the question of, I have some questions about changes I'm noticing in my sexual body. Who would be the best person for me to talk to about that? Because the reality is 98% of your physicians are not going to be the right person to ask. I would look for the nurse. If you have a lot of health issues, if you have a case manager that helps you, that you have a relationship with, I think you can also get online. Now in Oklahoma, your opportunities of looking at AASECT and finding AASECT certified providers is pretty slim. I know in Tulsa we have a sex therapist that's AASECT certified, and hopefully me any day now.
We're waiting.
Any day now. I think the Rona slowed them down a little. You know, but we'll be the only 2. There are other people who do sex therapy, and I think that's good to ask. But I think finding someone who's comfortable sexually, I always send men to a urologist and women to a gynecologist. If they don't have anybody else, at least they are comfortable in that body area. So that's where I'll usually send people outside of our system. And of course, now I'll be able to talk to them as well. But I want them to not feel like they have to reveal their whole story right up front, but just say, hey, I've got some issues. Would you be comfortable? Is there someone better for me to talk to about that?
Okay. In your work, I'm sure you see all sorts of people. How have you seen this impact the LGBTQ plus community as well, in terms of being able to ask for help, being able to seek treatment, have those appropriate conversations, especially if they're gender nonconforming, for example, or trans, right? And they have they're trans woman or trans man, right? And they're experiencing a diagnosis within one of their body parts that they no longer identify with. What is that part like?
I will tell you, in Tulsa, we don't see a lot of that. We do from time to time. I mean, you know, in every crowd are the quiet, are the quiet, unassumed ones that you don't know till you're with. I think in the medical community, and I'm thinking over 31 years, you know, of being a nurse, I think that I've never, outside of one time, encountered a situation where anybody was treated less than respectful. And the person who was treated that I'm thinking of in my head was actually not the medical provider who was being less than respectful to that individual. I know for the people we have at cancer treatment, I mean, for me, it's about joining whomever I'm with in the world they're living in, not asking them to live in my world. So I think in my own practice, judging from the people who are in my practice, I think they feel that out of me. I mean, I will tell you, people of color are always, I'm always amazed at how much they want information but have not had access to information. Even about just regular diagnoses, high blood pressure, what does that mean in my body? Diabetes, what does that mean in my body? And we've really seen that playing out in the COVID war, right? Because it's all those people who have those unmanaged diagnoses that are struggling. So I think we just have to be willing, no matter whom the person is in front of you, to take care of them in whatever space they live in. And I don't think I'm probably in the majority. I don't know.
No, absolutely not. I would say you're not in the majority, but definitely in a space where we need that kind of support. You know, the piece that you said that stood out to me is I join them in their world. I don't ask them to join mine. And so we can have different views in the people we serve, and that's okay. Right. But when we are there and when we're with them, we live in the world that they live in, because I'm sure outside of us, they experience enough. So when they come to us, right, they're really looking for help and support, kindness, and again, that compassion that I pointed out to you earlier that I think is really, really evident here. What are your thoughts about children who receive a medical diagnosis that will impact their, current or future sexual future sexual wellness, including function and fertility, because children receive some of these very harsh diagnoses in terms of cancer as well?
I think depending on the child's age, if it's a young child, we're probably really not even thinking that far ahead. For those that are in their teens, when they're diagnosed, you see a lot of sarcomas and different bone kind of cancers and things in kids. And a lot of those kids do have long-term fertility struggle. Diabetics who are diagnosed in their youth, anything that's diagnosed in your youth, the great thing is that those kids are now living, right? Where 10 years ago they weren't living, so we didn't ever have to worry about it. But now science has gotten us to a place where we do have to handle it. And it's probably, I think in those children's centers that deal with teens, I think they're probably good about that conversation. I think if you're not in a center that's used to dealing with a lot of kids, then maybe that's not as open, but it's going to be just like adults. What are they going to learn? Are they going to be learning truth, or are they going to be learning what is it that they're learning? I when we were in class and I learned about the sex ed thing, that sexual education in our schools is not required to be medically accurate in a numerous number of states. And all I could think of is, what?
Yeah.
What?
Absolutely. Absolutely. It's amazing. And Michigan is one of those states.
Oklahoma is too. And we're the buckle of the Bible Belt here. So it's a pretty rough world out there.
I can only imagine that in the way that you, but I mean, in the position that you stand in, right? So you have no other choice but to be an advocate, because it's a very, like you said, difficult conversation, private conversation. There's a lot of religious aspects built around that, and that's a lot to kind of navigate in the work that we do. David, and I had a conversation about that with David, and it can just be a very serrated edge sometimes for people to try and get over or go over to get help. What are the things that people tend to ask you most?
Probably in the cancer center, it's going to be for women. A lot of that is body image. You know, you think about what our society tells us about our hair, our eyelashes, our boobs. You know, we get some pretty heavy messaging about that. And we get a lot of visual messaging about what the woman should look like. And I don't know that I've met a woman yet in my 50 plus years of life that doesn't have something about them that they don't feel confident about. So I think body image and body love is huge. Going through something that can be so altering with scars and hair loss and changes in pigmentation. There are a lot of drugs, and there are some radiation treatments that will turn the skin color of people of color will turn it much darker. And for some people, that's a really negative impact. So just being able to have a conversation with somebody, you know, I want you to be prepared that this can happen. Here are the things that we can try to do to stave it off or to lessen it, have less impact with good lotions and creams and massage. But do know that it happens. You know, when women have to have surgery in the vulva, the labia, you know, you can get cancer there. And so, of course, that changes the look, right, of what they've always had. And that might change the look for a partner. And what's that impact going to be? An ostomy, think about a colostomy or a urostomy for bowel and for urine. And now it's sitting, you know, in a bag outside my abdomen. How does sex work through that now? So I think body image is a huge thing for a lot of people. And then, of course, you get into the sex thing. But the most overarching that impacts us all in some way is that body image. Because we're told what's sexy, right? People have no problem telling us
Absolutely.
what's sexy and what isn't.
No, I'm all there with you. We live off of between social media and television and even news outlets, what's sexy, what's worn, how you should dress, what this looks like. And I think mostly what I hear is what's not sexy, what's not hot, what's not appealing, right? And we don't teach this idea that that's a very unique and subjective experience, right?
Well, and I think it's a great one for age too, because I think, you know, there comes a place in your life. I was 38 when my big aha moment went from living a life that was about what everybody else expected of me and learning to find out who I was and who I wanted to be in the world and whose opinion I was going to let have any power inside of me and who I didn't give a dang what they thought. You know, and that's one of those, I think, life lessons, that chance to look back and reevaluate that. But I want to tell you one really important thing that I get to do with people is help them, as we're talking about the overarching. As people go through treatment, they disassociate a lot of their brain from their body because bad things are happening in that body, right? People are touching me that I really never wanted touching me. I'm having procedures done that are altering my body looks, or for women who have GYN cancers, you know, they're being very invased throughout this experience. Rectal cancers. So I think that that's an important issue to address, but I also think end of life is an important issue to address. As our people go through all of their treatment, we don't always get good stories, right? And I think those are the perfect couples for me to see as well, because now we can really try to put in perspective the cancer time versus other part of their life. And they've been so focused on this cancer story or this chronic health issue that they've kind of gotten lost to who they are as husband and wife.
Mm-hmm.
And we don't want that to stay that way, right?
Mm-hmm.
We want them to be able to close out in a different space.
Mm-hmm.
And so I think being able to sit with people and have good conversation about, and for me, I just call it the meaningfulness of who we've been together through this cancer journey, and what that next step in the journey is going to look like, and how they together can use that time. Because a lot of couples, when they get to that hospice close time, really it's become a very clinical relationship, right? The caregiver's been taking care of the patient. And I think it's really important for us as healthcare providers, as we're preparing them for that time, to also be preparing that couple for closure. You know, can we get them in a bed together? Can we, you know, do we make sure there's plenty of private space where everyone knows to leave them alone? You know, there are things that we can do even at the end of that piece of journey that are very intimate in a marriage.
I really love that. That's something that I did not know. And so to have that space where it's really important to provide a couple some comfort and meaning and authenticity around their marriage and what their relationship has been, or lifetime partnership has been, I think I could see how much differently people may grieve if they really do have that opportunity for closeness as they know they're nearing the end. Right?
And, you know, we don't do much better with talking about death than we do talking about sex.
Yeah, they're in the same wavelength. And it's so funny because when you ask people, well, what happens if you're not healed? What does that look like? Are you prepared for that too? And a lot of people say, oh, I don't want to think about that. I don't want to bring death in the picture. I don't want to give life to that. And I get that. I understand wanting to be positive, but you also have to be realistic and aware.
I usually will ask folks, or my comment is usually, you know, in 31 years of being an RN, and 35, I think, since I started working in a hospital. I started working in a hospital at 17. I don't even know where I was going with that. I tell people that healing comes, that's where I was going. Healing comes in so many different ways. Healing comes in our mind, in our body, in our spirit, in our heart, in our relationships. So it's not just health. When we talk about being healed, healing can come in so many ways. And so trying to help people move away from just healing, meaning that I'm going to be cured of cancer, but what other ways do we need healing in our life? And maybe that's the healing that we're going to be able to recognize through that experience.
Well, I'm sure after everyone watches this video, Traci, they're going to measure their nurses against you and their experience, right? To kind of check and see, is that person really giving them that compassion? Are they having this wholehearted, whole body experience? Really what I say is, are they being seen?
Are they being seen and heard?
Yeah.
Does my story matter? Or am I just another cattle through the cattle chute of medicine? Does my story matter?
Absolutely. So let me ask you this. Is it your opinion that, you know, what you do, your position, what you offer as a sexuality, you know, counselor and educator, that this should be something we see across all areas of the field?
Absolutely. And I feel like that's, you know, my own personality, Traci comfort zone, would never have me doing a lot of the things that I'm doing. I'm going out to support groups. I'm going into other facilities. I'm going into churches. You know, I'm going into some places where that can sometimes feel uncomfortable, but I know that I've never been called outside of my comfort zone, that I haven't been equipped. So I just am going to continue marching boldly, because right now my fight is just within the enterprise of Cancer Treatment Center. We need to have a nurse at every site. I can't, you know, there's no way for one girl to be at every site. So
Mm-hmm.
find some nurses. Let's train them up. You know, in every facility, there's going to be at least one nurse just like me going, heck yeah, I'll do it. I'd love to do that. That sounds awesome. And then, so I'm working to train some other nurses at other sites. So I do hope that we see this everywhere. It's a growing part of our oversight body. Many of our oversight partners really talk about conversation of sexual health as part of caring for a person. So you never know. I thought I was really behind when I got started on this journey. I thought that everybody else was miles ahead of me on this journey. And then when I got into it, I figured out there was no path. So really we're taking the machete and we're cutting a path as we're trying to move forward through it. So I say yay for us for being willing to go in hard places.
Yay for you. Absolutely. So here's your bonus question, Traci. How do you talk about sex in your own family? You've been a parent, you have little ones, you got little grandchildren running around. So what does sex talk look like with Traci at home?
I think most people will tell you it's very open, and it always has been. I raised our children to know their body parts, the appropriate names, how they function. My oldest daughter, I think, was 15, and she had struggled with periods from the get-go. She has polycystic ovarian disease, and I think she was 14 or 15. We're in the GYN's office, and at the time I was director of emergency services, so you know every physician at a facility that way. And he sees her and he says, okay, well, I'm going to put you on birth control pills to try to regulate your hormones so we can see if we get a better balance in your body. Now, these will not, birth control pills will protect you from pregnancy, but not from sexually transmitted infection. And he starts to say something else, and my 15-year-old puts her hand up and she goes, Doc, I could give you this conversation. And he looked at me and I was like, yeah, she probably could. And then I have a 6-year-old granddaughter and a 6-year-old grandson, and we just recently bought the book, and my granddaughter and her mom read it, and it's about boy parts and girl parts, who has what, and another one is on consent. And so my daughter and granddaughter are reading it. Now it'll go to my son and those grandkids. And but I've had great conversation after my granddaughter read it. I said, well, tell me what you learned today. And she goes, so she just went through and was able to tell, so comfortably talk about what does consent mean? If I haven't given consent, what should I do with that information? How do I protect myself? So yeah, we're pretty open about it. I mean, it's part of who we are as human beings. So hello. Don't put it in the closet.
Don't put it in the closet. Keep it out in the open, right? It should be on the coffee table where everyone can see.
Well, my family laughs because you walk around this house and there's just you'll never know what you're going to pick up to read.
All right. As I wrap up, what do you want to leave with people in terms of what do you see as important and valuable here? What do people need to know?
I think people first need to see themselves as a person of value and of worth, right? Because until I have value for myself, how am I going to promote myself? So I think doing what you need to do inside of yourself to find out who you are, and I think finding that person that you feel meets those needs within you. But then as you transition through life, just know that body's always changing. And so if we don't go with it, right? I see a lot of men who get stuck thinking about their 20-year-old erections, but they're 70. And so we have to really level set that, right? We have to be like, you're not going to have a 20-year-old erection anymore because you're 70. So I think just giving people permission is our biggest thing. Permission to have a discussion, to evolve with their body, and to be curious about not getting stuck in what they can't do, but being curious about what they can do.
Be curious. So, Traci, would you say sex is healthy?
Absolutely. It actually has physiological known benefit. We dump great endorphins into our brain when we have sex. We have deeper REM sleep when we have good orgasmic sex. We're more fulfilled physically when we have connection with people. So it's anxiety relieving, it's depression relieving. We should all be having sex.
Have sex.
We don't even need somebody to do it with.
Nope. They make some great things, some great toys out there for solo play, partner play, have sex, lubricate your joints, right?
And how do I have good sex if I don't know what good sex feels like?
Absolutely.
Because my body in my 50s is much different than my body in my 20s.
And I think that's an excellent point, because the way you take in sensation, right, at 20, when you're loose, open, no worries or responsibilities for some people, is much different when you're in your 50s or 60s, 80s even, right? Some of my older clients are in their 80s and 90s, and they are having sex, whether it's with a partner or by themselves, right?
That's what I'm saying.
So, hey, listen, I'm trying to get up there. I want to stay active, but it's no different than the rest of your muscles in your body. You use them or you lose them, right? And you have to be curious about other ways to use them when the functioning has changed. All right, Traci, so we're going to wrap up here.
Thanks.
I really appreciate you joining us on Sex Ed for Adults. Go ahead.
Just saying thanks. I had a good time. It was great to see you. And that smile. Oh my God, I've always loved that smile.
That I appreciate. I really do. So all the way from Tulsa, Oklahoma, we got some expertise from Traci, a registered nurse, a sexuality counselor and educator who works in oncology and has a breadth of knowledge, a wealth of knowledge that expands a 30-year career. So Traci, I am really humbled by you joining me, you having this conversation and providing information to people that they might not otherwise get. As you all remember, like, share, and follow, and we'll see you on the next episode and at the next intersection. Peace.